I'm going to just start the presentation. We'll be looking at the nursing home demographic, which many of you are very familiar with. We'll be particularly focusing on symptom presentation in COVID-19, with particular reference to the end-of-life phase and the supportive measures that we can employ in terms of controlling these symptoms. I'll be touching briefly on communication with families, and if we have time, we'll also speak about care after death as well. So thank you. So in terms of nursing home residents, we have 29,000 nursing home residents nationwide, and these patients are characterised by those with multiple comorbidities, high levels of dependence, and in whom frailty and significant cognitive impairment is characteristic. Many of these residents are in their final year of life already. And we already know that the levels of mortality for COVID-19 illness is highest in this age group. And this has been borne out by studies performed in China and also in Italy in particular. We know that nationally, 1 in 5 people who develop COVID-19 are actually in a residential care setting. And as of yesterday, we've had over 90 confirmed outbreaks in residential care facilities. So this really is a very significant problem that we have to contend with, and we have to think about how we can best deliver care to these residents in a care setting that's commensurate with their needs. Just in terms of why care home residents are particularly vulnerable, we're all aware that the immune response dwindles with age, thus putting people in residential care facilities much more at risk of contracting and developing severe illness. We also know that the comorbid conditions that people have that lead to poor outcomes are commoner in the elderly population, particularly cardiac comorbidities, diabetes and cancer. In addition, patients in residential care often require a high level of physical contact to provide their personal ADLs, which can increase the risk of transmission. Because of impaired cognition, residents are going to be less able to comply with infection control precautions and hand washing. And if you think about the actual environment, residents are living in socially congregated areas, many of which have limited isolation capacity. I'm not going to dwell upon the constellation of symptoms of COVID-19 because these have been widely described and disseminated, but just to be aware that many patients, many people do have asymptomatic presentations of COVID-19, and this has been estimated as being anything to between 15 to 20%. And we also need to be mindful that in older patients or in patients who are immunocompromised, their presentation of COVID-19 illness may be atypical in nature, in that often older people may manifest with just new onset delirium and very subtle respiratory symptoms. Typically, the trajectory of COVID-19 illness can manifest with escalation at the 1 to 2 week time frame, with progressive respiratory distress characteristic of development of an interstitial pneumonitis. And this can also be compounded by hypoxia, air hunger, development of a significant delirium and high-grade pyrexia. This particular symptom constellation can develop quite rapidly, and as such then may herald the end of life, particularly for people who've got multiple comorbidities and a low level of functioning. Of note, pain is not a prominent feature, particularly with COVID-19. So just looking at this slide, this again illustrates the impact of comorbidity, particular cardiovascular disease and diabetes. And it's felt that the higher level of mortality with cardiovascular disease is probably reflects the limited reserve that people with cardiovascular disease have from a respiratory perspective, and also the propensity to develop arrhythmias with this particular illness. And you can see here from this particular graph, it's illustrating the mortality rate in the older populace. And we know that anybody over 80 has a 14% chance of dying during this illness. So that's an important figure to take home. In terms of treatment escalation plans within nursing home settings, this is something that is well established within nursing home care, and is that nursing home staff within nursing home settings have skills and a lot of experience in establishing these. But in terms of looking at treatment escalation plans that can be provided within a residential care setting, the key question is really whether or not patients are appropriate for acute hospitalisation to avail of parenteral fluid, antibiotic or other supportive measures. And I suppose the focus primarily from the government and from the health service has been to try and look after patients with COVID-19 within the setting of residential care in as much as is feasible. There also needs to be clarity around do not attempt cardiopulmonary resuscitation, and looking at availability of oxygen as a symptom control intervention and as a supportive measure. And also looking at the role of medication to alleviate symptoms, particularly breathlessness, delirium and chest secretions. The bottom line really is that we cannot say that patients within nursing homes that there's going to be one size fitting all in terms of whether or not they're appropriate for hospitalisation. We do need to take into consideration other factors when we're making decisions around the appropriate level of intervention. And I suppose the factors that we need to consider is around whether what somebody's pre-morbid level of functioning is, whether they have potential to benefit from hospitalisation. And we know that hospitalisation may not necessarily be helpful nor appropriate for people who have a very high level of dependence, who have established cognitive impairment, and who are unlikely to be offered non-invasive ventilation or escalation to acute care. It is important that we do take into consideration people's previously expressed values and preferences with regard to this, and also that we would consult with their families and their nominated next of kin to elicit this. So just moving on to recognition of final days of life, I think it is important when people have got COVID-19 illness and their symptoms are changing, that we look for any potential reversible cause, particularly superimposed infection, which may warrant treatment with either oral or intramuscular antibiotics, look at medications that might be contributing towards deterioration, look at concurrent dehydration, and also discuss realistic levels of intervention with patients where possible and or their family members. I suppose some of the cardinal signs that end of life is approaching are primarily focused on the respiratory symptoms, particularly increasing dyspnea at rest or dyspnea when tending to personal care, desaturation whilst on oxygen therapy, or development of a delirium are poor prognostic indicators. In conjunction with that, patients may manifest with reduced ability to verbally communicate and may have increasing difficulty managing oral medication, diet and fluids, and may be developing early oropharyngeal secretions. One of the key things to emphasise is that this symptom constellation can develop quite quickly, and it's important that we preemptively ensure that we have the appropriate strategies in place to deal with these symptoms as they develop, particularly in the out-of-hours setting. So anticipatory care and anticipatory medication provision is absolutely key to responding to the symptom needs of these residents. So if no reversible cause is identified and the resident is felt to be approaching the final days of life, there are a couple of things that we need to be focusing on. We need to be clearly communicating this to family members in particular. And this is a difficult conversation to have at the best of time when people are able to have these conversations face to face, but they're equally more challenging to have this conversation over the telephone. We need to have clarity around the goals of care. And I think it's important to emphasize that if somebody is deteriorating with COVID-19 illness and they're not for hospitalisation, that it isn't that we're offering a withdrawal of care or that we're that there's nothing more that can be done for this particular patient. We need to reframe and emphasize that the focus is going to be on managing the patient's symptoms, and that the patient is going to be in a place of care that's familiar with them and being looked after by healthcare professionals that have the skill and the knowledge of this individual to care for them appropriately, and to ensure that they achieve a comfortable death. We need to think about current symptoms and also anticipated symptoms, and these include physical symptoms, but also the psychosocial needs of the family, including spiritual care. And we also need to think about using communication to non-clinical staff within the facility, particularly catering staff, cleaning staff, and considering using the end-of-life symbol to communicate this to other team members. Important tasks we need to focus on as end-of-life approaches would include supporting the resident to enjoy sips of fluid as long as the person wishes. And this can be in the form of chilled water, ice chips, or even flavoured drinks if the patient wishes. We certainly wouldn't be advocating that patients would be deemed to be nil by mouth, even if they are showing stigmata of aspiration. I think careful and meticulous attention to oral and eye care is very key, and we would normally advocate the use of a water-based gel such as BioExtra or a spray on a 2-hourly basis, and the avoidance of glycerine swabs, as these can excessively dry out the mouth. The eyes also will need attention, and the use of topical hypomelos drops up to QDS can also prevent corneal drying and ulceration. The patient should be repositioned regularly to ensure comfort and to minimise pressure area compromise, and this has to be balanced against the needs of healthcare professionals going in and out of patients' rooms, and also against the requirement for use of PPE. And also careful and meticulous attention to bowel and bladder care is also key at this juncture, particularly watching out for features of urinary retention or fecal impaction. In terms of looking at medication management, we would advocate looking at the patient's regular medication and discontinuing any medication that is not in keeping with ensuring symptom control, particularly regular medications such as anticoagulations or antihypertensive. And also looking at the need for anticipatory medication provision for common symptoms that we would anticipate, and to think about how these medications are going to be administered. And by and large, in a residential care setting where there's qualified staff available, we would advocate the administration of medication by the subcutaneous route to facilitate this. And I'll be talking later about placement of subcutaneous lines to facilitate administration. There are particular oral medications that patients may be on that may need to be replaced, and the questions, the medications of note in this type of situation would include background opiate therapy, that this may need to be replaced, background benzodiazepine therapy, which if stopped suddenly can precipitate a withdrawal symptom, and importantly anti-epileptic medication, because stopping that may provoke seizure activity at end of life. It's important to discontinue any investigations or interventions that are unlikely to be of benefit for the patients at this juncture. So things like routine monitoring of vital signs apart from temperature is not indicated. And then looking at the role of subcutaneous parenteral fluids, this can be quite a loaded issue for family members in particular who may have concerns about their loved one condition deteriorating due to a lack of oral fluids, and there may be concerns around the patient dehydrating to death. And I think it is important that we'd explain to family members that often as end-of-life approaches, patients will often have a diminished sensation of thirst and have a reduced requirement for oral for fluid intake, and that the role of oral care in terms of alleviating the sensation of thirst is vitally important. And really it is the evidence around the provision of artificial hydration at the end of life phase, the evidence base is quite inconclusive as to whether or not it actually has a significant role in terms of extending life, or whether it actually prolongs the dying process. And provision of subcutaneous fluids may indeed actually contribute towards increasing peripheral edema and increasing breathlessness, particularly chest secretions as end of life approaches. So this needs to be carefully communicated to family members in particular. So these are the common symptoms that we contend with at end of life, and breathlessness, anxiety, delirium and chest secretions are the ones that we are encountering in dealing with COVID-19 patients in particular. Looking at medication delivery, I mentioned the role of subcutaneous administration, particularly in the nursing home setting. And this provides a route to administer medication that's equally as efficacious and less painful as administering medication intramuscularly. And you can see from this diagram that the subcutaneous lines can be sited on the lateral aspects of the arm, the lateral aspects of the thigh, or in the anterior abdominal wall. And the subcutaneous lines can stay in place for up to 5 days once the site itself doesn't become erythematous. If a patient becomes quite agitated or distressed and is concerned about the line being dislodged, well then the line can be sited posteriorly on the back, just below the scapulae, which can make it more difficult for the patient to pull it out. In terms of procurement of anticipatory medication, it's important that we liaise early with the relevant general practitioner, the local pharmacy, and equally the local specialist palliative care team for advice around the appropriate medication to administer. And again, it's just to remember that many of the parenteral drugs that we're using around symptom control at end of life can be used for more than one indication. And really the 4 staple drugs that we would be recommending would be morphine sulfate, midazolam, an antipsychotic such as levomethomazine or haloperidol, and an anticholinergic such as buscopan. We want to try and minimize polypharmacy in this situation and also minimize the cost. And we have been assured that there is no concerns about supply of these particular 4 medications within the community and in the hospital setting. So we would advocate that residential care settings wouldn't stockpile these medications. There have been a number of designated pharmacies within the Midwest that are going to carry the stock of priority medication, and they're also these are have been developed in line with the HSE guidelines on anticipatory medication delivery and syringe driver prescribing. So just moving on to symptom control. The primary symptom is that of breathlessness, which can be compounded by superimposed anxiety, spiralling, and a sensation of air hunger. And people may manifest with breathlessness with normal oxygen levels, or whether if they're hypoxic. So the important issues to consider in the first instance is to consider contributory causes to breathlessness other than COVID-19, and consider treatment of infection if deemed to be present, and also to look at provision of oxygen if a patient is proven to be hypoxic. To think about positioning of the patient, particularly in at 45-degree angle, and to reduce the ambient room temperature, and use non-pharmacological strategies such as cooling the face by flannel or a cloth to help to alleviate the breathlessness. It is important within the context of the COVID-19 epidemic to remember that portable fans are not currently recommended, as they can increase aerosolization of infection. And the primary drug that we would recommend for alleviation of dyspnea in the context of COVID-19 is opiates. So administration of morphine sulfate 2.5 milligrams subcut 4 hourly can be used to relieve the sensation of dyspnea and to alleviate coughing. And this can be used in conjunction with midazolam to alleviate the anxiety and spiraling component of breathlessness. It's important that following subcutaneous intervention that we evaluate the effectiveness of administration of the medication, and to remember that medication maybe need to be administered in combination, so an opiate and midazolam together as opposed to singly, and that doses would be titrated in response to the effect of the medication. So if morphine 2.5 isn't having the desired effect, then we need to step up the dose to 5 milligrams. If somebody's already established on a background opiate, the PRN dose then needs to be calculated with this in mind. And the PRN dose is typically 1/6 of the total equivalent subcutaneous dose. And in addition to that, if somebody is already established on an oral, has been on an oral benzodiazepine or an antipsychotic agent, higher doses of midazolam may be required to address breathlessness. So moving on to delirium, this is quite common in those with pre-existing cognitive impairment and in the nursing home cohort, and it can manifest as hyperactive delirium in that, you know, people with combative behaviour, agitation, or with hypoactive features, be it lethargy, withdrawal. And it's estimated that up to 1/3 of elderly patients with COVID-19 may manifest with delirium. Again, just emphasising the importance of non-pharmacological measures to deal with this, including environmental strategies and familiar staff, looking out for reversible elements, including ruling out urinary retention, ruling out an intercurrent fever, ensuring that the person doesn't have pain, or looking for subtle features of opiate toxicity, which may warrant an opiate switch to address. In terms of managing delirium, in the first instance, we would recommend low-dose antipsychotic therapy and the avoidance of benzodiazepines, because these can paradoxically agitate delirium in the first instance. So the agent of choice that the national guidelines is recommending is levomepromazine 6.25, which can be administered subcutaneously 4-hourly. There have been supply issues with haloperidol of late. If delirium is escalating and it's clear that somebody's approaching the final days of life, then administration of a stat dose of levomepromazine 12.5 or haloperidol 1.5 to 3 milligrams may be warranted. And in the end of life situation, the use of an antipsychotic and a benzodiazepine in combination may be required at 4-hourly intervals to manage the symptoms of agitation and restlessness. It's important that hyperactive delirium in particular is managed intensively, and again, the big thing really to remember is that should patients not be responding to initial doses, then it's important to liaise with the specialist palliative care provider to get advice around dose escalation and to look at the intervals of dosing. Moving on to respiratory secretions, this is common if there's an underlying respiratory diagnosis, if there's stigmatofluid overload, or if a person has documented intracranial disease. Patients can be regularly repositioned, and often the nursing home staff will find that patients may be more comfortable on their side or on their back, and an explanation to family members around the nature and the meaning of respiratory secretions is important. We would not advocate employing suctioning, because this can be an aerosol generating procedure and can result in dissemination of the virus to other to healthcare professionals within the room. And then from a pharmacological intervention perspective, administration of buscopan, 20 milligrams at 4-hourly intervals can help to alleviate the secretions. If there's concerns around fluid overload, or if the patient has a documented history of congestive heart failure, administration of a stat dose of furosemide 20 to 40 milligrams subcutaneously can be of benefit, and the response to this can be established by looking at whether or not the patient diureses. Fever can also be a very prominent feature, particularly as COVID-19 disease progresses, and the usual antipyretic measures of administration of paracetamol and looking at tepid sponging and looking at a reduction in the ambient temperature can be of particular benefit. There has been a lot of debate around the role of non-steroidal anti-inflammatories in COVID-19 disease. But really, if somebody's approaching the final days of life and they're manifesting high-grade pyrexias, I think it's reasonable to administer a non-steroidal, such as diclofenac, 100 milligrams PR, to ensure that comfort is addressed at end of life. Just moving on finally then to looking at medication delivery via continuous subcutaneous infusion. Particularly in nursing home settings where you've got qualified staff available and the ability to administer medication via the subcutaneous route, the need for a subcutaneous infusion may not be required. We certainly have scope to adjust both the dose and the frequency of PRN subcutaneous medication to address the patient's symptoms. And certainly the delivery of medication via syringe driver can be replicated by prescribing regular 4-hourly morphine sulfate in conjunction with regular 4-hourly midazolam to replicate delivery of medication via syringe pump. And the patient can, you can also prescribe PRN medication that can be administered in the intervening interval, say 2-hourly, should the patient require it. There are competencies around setting up a syringe driver and reloading a syringe driver that many healthcare professionals within the nursing home setting may not have, and there also are concerns around the number of devices that we have to provide. So if we can replicate administration of opiate and midazolam and anti-secretories on a 4-hourly basis, it may obviate the need for administration of medication through a syringe driver. And there has been HSE guidance developed to support this in particular. And equally, if the subcutaneous route is not available, well, then medication can be administered via alternative routes, including the oral dispersible route. So antipsychotics such as olanzapine or risperidone can be administered on the tongue or under the tongue. And we've already mentioned the role of lorazepam, 0.5 to 1 milligrams, which can be administered sublingually, both for anxiety and for dyspnea. Midazolam also comes in a buccal preparation, and this can be administered 2 to 4 hourly buccally for anxiety and dyspnea, or at a higher dose of 5 to 10 milligrams stat in the event of seizure activity. In terms of medications delivered by the transdermal route, we would probably not advocate transdermal medication delivery unless the patient's symptoms are relatively stable, because there can be a lag in the absorption of this medication, and also the absorption of medication from the transdermal route can be affected by high-grade pyrexia in particular. Nevertheless, if there are issues around supply of anticholinergics, well, the role of scopoderm patches, 1.5 milligrams, 72 hourly, can be looked at, and this can be placed behind the ear. And equally, there are a range of medications available via the rectal route, which again can be looked at to administer, including rectal non-steroidals, which I've already mentioned, rectal diazepam instead of subcutaneous midazolam, or some anti-epileptics also come in rectal preparations, particularly carbamazepine, and we would be recommending the use of these to replace anti-epileptics that are already established, as opposed to initiating de novo.